Hi, I'm James Stuckey. In this video, I will talk to you about the primary spinal surgery objectives and the common spinal surgery approaches and procedures for degenerative pathologies. There are four primary spinal surgery objectives: decompression, alignment, stabilization, and fusion. I'll begin with decompression. To decompress in spine surgery is to take pressure off the nerves. So if there is stenosis and neural impingement that is creating symptoms of radiculopathy, which is radiating pain in the limbs due to compressed nerves, or myelopathy, which is spinal cord compression, the surgeon will attempt to remove tissue or otherwise create space in order to remove any pressure on the nerves or spinal cord. A direct decompression occurs when the surgeon is directly removing the bone or the tissue impinging the nerve. Generally, this technique would include a small midline or off-midline incision and exposure of the posterior bones only. An indirect decompression occurs through the use of an inner body implant that restores the disc height and/or reduces a spondylolisthesis. When the disc height is restored, the intervertebral foramen, central canal, or both increase in volume, thus indirectly decompressing the nerve. In this type of decompression, the bone or tissue compressing the nerves are not removed from the patient, thus it is an indirect decompression of neural structures. Alignment has long been an overlooked component of spine surgery, but that has changed as we now know more today about the correlation between alignment and clinical outcomes. A patient comes into surgery either in or out of proper spinal alignment. If the patient is in alignment, the surgeon will want to preserve this. If the patient is out of alignment, the surgeon will want to restore alignment. The intricacies of alignment will be discussed further in the Integrated Global Alignment courses. After decompression and alignment, the surgeon will need to stabilize the patient in this position. Decompressions can cause destabilization of the spine, so it is important to use fixation such as pedicle screws to restabilize the spine. Think of stabilization like internal casting. The most common method of stabilization is fusion, or elimination of motion between two or more vertebrae through bone growth. Fusion is often necessary when there is a deformity that needs to be corrected. The surgeon may manipulate the spine in ways that correct a deformity, but to hold the correction permanently, the spine will need to be fused in the correct position. Fixation used for stabilization can also facilitate fusion. The surgical maneuvers used to take away hard or soft tissue and/or make space for the nerves are named for the anatomy removed and the suffix ectomy, which means to remove all of, or the suffix otomy, which means to cut through or remove part of. In the case that only a small amount of disc needs to be removed to decompress the neural elements, it may not be necessary to perform stabilization and fusion, but rather make a small incision and remove the herniation. This is commonly referred to as a microdiscectomy. Similarly, if only a small amount of bone needs to be removed to perform decompression, the surgeon can perform a hemilaminectomy or laminotomy to remove the bone. The amount of bone removed and stability of the spine will determine if the surgeon needs to stabilize with the use of supplemental fixation. A direct decompression procedure that can require the most supplemental fixation is a laminectomy. In this procedure, the surgeon is removing the entire lamina to decompress the neural elements. You can think of this procedure as removing the roof from the rest of the house. Another type of decompression is a foraminotomy. In this procedure, the surgeon is removing bone or tissue surrounding the foramen in order to make it larger. This, as a result, would directly decompress the nerve. Lastly, fascicectomy is the partial or complete removal of the facet. If performed partially, the surgeon will typically resect the medial portion of the facet. A fascicectomy can be performed bilaterally, such as in a PLIF, or unilaterally, like in a TLIF. Following decompression of the neural elements, a fusion procedure may be carried out if the surgeon would like to stop the motion between two or more vertebrae. One common type of fusion procedure is a posterolateral fusion. In this procedure, the surgeon will place bone graft in the posterolateral gutters on either side of the spinous processes. In addition, they may also lay bone graft across the transverse processes of the adjacent vertebrae. One of the most common types of fusion procedures you will likely encounter is interbody fusion. Interbody fusions have become the standard because they provide better surface area, stability, carry more of the spinal loads, and are better vascularized than posterolateral areas. Interbody fusion procedures can be performed from different approach directions, including posterior, anterior, lateral, and from both the front and the back, commonly referred to as a 360 fusion. A very common interbody procedure in the cervical spine is an anterior cervical discectomy and fusion, or ACDF. This is the surgery that is performed to remove herniated or degenerative disc in the cervical spine. The incision is made over the anterior spine through the throat area. After the disc is removed, an intervertebral spacer with bone graft, allograft, or harvested autograft is inserted to fuse the adjacent vertebral bodies. A plate is typically added to provide extra segmental stability. Posterior approaches are also utilized in the cervical spine. Posterior cervical fusion, or PCF, is a surgery to relieve cervical spinal cord pressure and/or myelopathy. The incision is made in the posterior anatomy and fixation is placed to provide added fixation or stability for the operative levels. Next, the lamina is commonly removed over the offending pathology, thereby providing relief of pressure on the spinal cord. Finally, bone graft is placed in the decorticated lateral gutters to promote bony fusion. Another less common procedure in the posterior cervical spine is the laminoplasty procedure. This is a surgery to relieve cervical spinal cord pressure and/or myelopathy. The incision is made in the posterior anatomy and the lamina is partially cut on both the right and left sides. This creates a hinge on one side of the lamina and a small opening on the other side. The lamina is then moved into the open position by elevating the lamina on the open side. This vastly increases the space available for the spinal cord and takes the pressure off of it. Allograft is usually inserted for fusion, and a plate is added for fixation and stability. Next are lumbar spine procedures. First is anterior lumbar interbody fusion, or an ALIF procedure. With the patient lying supine, an abdominal incision is made and a trans or retroperitoneal approach is performed to gain access to the diseased disc space or spaces. Careful attention is made to avoid both anterior nerves and vascular structures. As with any procedure, there are both pros and cons. To touch on just a few positives of ALIF, it is great for L5-S1 access, allows for direct visualization of anatomy, and preserves posterior muscles, bones, and ligaments. Negatives of the ALIF procedure include the need for a vascular surgeon, removal of the ALL, and potential challenges of above the aorta and vena cava bifurcation. One of the two most common posterior inner body approaches is the posterior lumbar interbody fusion, or PLIF procedure. PLIF is the oldest of the lumbar interbody fusion techniques, being first described in the 1950s. PLIF became popular due to the dissatisfaction with the posterolateral fusions that did not utilize interbody fusion. PLIF is still a very common procedure and very effective technique, but requires a large exposure and significant bony removal. The procedure includes partial or complete laminectomy, retraction of nerve roots and/or cauda equina, discectomy and end plate preparation, and placement of bilateral interbody implants. The other very common posterior interbody approach is the transforaminal lumbar interbody fusion, or TLIF. TLIF is a modification of the classic PLIF procedure performed unilaterally through the intervertebral foraminal space under the facet joint. It was developed to avoid the dural retraction required to get into the disc space from the back. The procedure consists of a unilateral fascicectomy to expose the disc space, retraction of the exiting nerve root, traditional discectomy, and end plate preparation with curved instrumentation, insertion of an inner body implant, and addition of posterior instrumentation due to instability created by removal of the facet. A few positives of posterior approaches is that they are common approaches to the spine with anatomy familiar to the surgeon, and they are a method to address many pathologies. Challenges include bony removal, which increases blood and instability, and potential nerve injury and radiculitis. This concludes part 1 of the spinal procedures video. In part 2, I will talk to you about the minimally invasive and maximum access procedures, corpectomies, and total disc replacements.